Good evening, everyone. I hope I am audible enough. Welcome to today's webinar. I think we are going to allow just 2 more minutes for the attendees to increase a bit more in number. Then before we then start our webinar for today. Welcome, everyone. Okay, I think we are about a good number now. We can proceed. So good evening again, everyone. Welcome to our webinar today, which is sponsored by KMA and Pfizer. Now, today's session is on pneumonia, and this is informed by World Pneumonia Day, which is commemorated every year on 12th November. And the aim of this is to raise awareness in prevention of pneumonia, which is a respiratory illness that contributes to a significant amount of deaths worldwide, and is a #1 killer in under fives. Now, before I introduce the speaker for the day, I'm going just to mention a few things about. So, if you have any additional comments about what you're speaking about today, you can post your comments in the chat box right below. If you have any questions, you can also ask them in the Q&A section, which will be answered during the Q&A session. Now, before I introduce our speaker for the day, I'm going to welcome Dr. Brenda Opondo, who is the CEO of Kenya Medical Association, for opening remarks. Dr. Brenda. Okay, I've been told that Dr. Brenda is not available. So without further ado, I'm going to introduce our speaker for the day, who is Dr. Andrew Owor. Dr. Andrew Owor is a renowned respiratory specialist at Kenyatta National Hospital, holding uh, he's under he got his undergraduate degree from and master's degree from the University of Nairobi. He also holds a diploma in respiratory medicine from the European Respiratory Specialist Society. He has a certificate in interventional radiology from Golnik, Slovenia. He also doubles up as a critical care physician. He's a member of TB Health Sector Working Group in Kenya. He's also a member of the Respiratory Society of Kenya, amongst being a member of several other bodies. He's an honorary lecturer at the University of Nairobi and also the Kenya Medical Training College. He's a delegate at the STEMA Circle. I can go on and introduce him, but I will not really finish. So I'll just let him begin the presentation for the day. Welcome, Dr. Andrew.
Thank you, Dr. Let me just share my screen. Sorry, my screen. As I share my screen, it gives me great pleasure once again to be before you. I think the last time I gave a talk to the wider KMA membership is about 2 years ago during the COVID pandemic when things were very thick. So it gives me great pleasure once again to be before you. Maybe so that you can see who it is. I think it's raining quite a bit where I am. But we'll try and see how we can be able to carry this forward. The task given to me today is a global impact of pneumococcal infections. Kindly somebody confirm if I'm on slideshow. Am I on slideshow, Dr. Bitok?
Yes, Doc, I can see your slides.
Okay, thank you. So good evening to you all. World Pneumonia Day is celebrated on the 12th of November each year, so it will be on Sunday this year. KMA saw it fit contributes much more to mortality even amongst adults. I am aware that the Kenya Pediatric Association is actually currently also having a concurrent CME on the same topic. So I decided to actually focus more on adults because I know that they'll be focusing majorly on children with regards to this topic. So for those who would want to hear more of adults, I'd recommend you kindly stay on. And for those who want to hear much more about children, I think the webinar was shared. And if you're here, then I am of the opinion that you actually wanted to hear much more with regards to adults. So our outline will be as follows. This is a disclaimer. This is the Pfizer sponsored webinar, and the opinions that I express here are my own and not necessarily of Pfizer. And I actually will be receiving honorarium from Pfizer. So the objectives of the day is actually, here we are going to specifically deal with the pneumococcal infection. So what we'll go through a little bit about strep pneumo, a little bit about epidemiology of pneumococcal infections, a spectrum of pneumococcal disease, the trends in pneumococcal disease, some risk factors, and then the impact of pneumococcal infections, as it were. So from your med school days, you can remember, I hope you can remember, strep pneumo is actually a gram-positive bacteria. You remember it's a cocci, so they're usually round in shape. For those who don't remember, this gram-negative positive bacteria can either be coccus or bacilli. So this one is a coccus. And there are 92 serotypes. This is important to know this. The virulence factor is actually the capsule of the bacteria itself. And generally, your body develops type-specific antibodies, which are protective. So generally, develop specific antibodies dependent to the strains that are available. There are the 92 serotypes that are there. So depending on the strain that you've been exposed to, then you usually tend to develop type-specific antibodies. And then there's limited cross-reactivity. The reservoir is actually the human. Transmission is usually respiratory or auto-inoculation. A temporal pattern is throughout the year, although there may be some peaks during the colder months because the pneumococcal infection tends to be a super infection, usually to viruses. So influenza virus, respiratory syncytial virus, adenovirus, which is common in children, and of course SARS-CoV-2 or COVID. The pneumococcus can actually be a super infection. Then communicability is unknown, but we tend to think it's usually by respiratory secretions that the bug manages to stay alive in the respiratory secretions. Just as a background, I've already mentioned a lot about the bacteria itself. It tends to be opportunistic and it usually lives in your mucosal surfaces. Of interest, 27 to 65% of the carriers are actually children, and only about less than 10% of the carriers are actually adults. Okay, a wider range of infections. We'll come to this later on, and it tends to be a trigger for many respiratory conditions. So just as a background, pneumococcal disease, the spectrum of disease is classified as either invasive or non-invasive, which tends to be mucosal illnesses. And these mucosal illnesses will generally be sinusitis and acute otitis media. Today, we are going to spend time on the red side. And basically, there's invasive where you have meningitis, you have bacteremia, and you actually have pneumonia, of which, with regards to pneumonia, 25% is invasive and 75% is categorized as non-invasive. Now, there's a lot of data, but the Americans seems to have the most organized data because they've been doing studies for a long time. So the incidence of invasive pneumococcal disease, this is a spectrum study over time with regards to 15 to 64-year-olds, where they were actually looking for who was at high risk of getting invasive pneumococcal disease. And as you can see, patients who had comorbidities had a very high risk for actually developing invasive pneumococcal disease. A healthy person had only an 8 per 100,000 chance, whereas if you are HIV positive, or if you have a hematological malignancy, you had a 20-fold risk of developing pneumococcal infection. To just bring you home, Kenya is one of the countries with the highest HIV burden in the world. And prior to the vaccination in children, basically the conjugate vaccine, the PCV10, the rates of infection amongst the HIV population was quite high. Actually, in Kenya, it reported about 5.9 per 100,000 persons in terms of the incidence. However, studies done after 2010, I think the last one I saw was by a colleague by the name Bigogo, actually showed a great reduction in the incidence of invasive pneumococcal infections amongst the HIV and also amongst the non-HIV, simply because, as I mentioned before, majority of the carriers of this disease are actually children. So by taking care of the children, then this has drastically led to a dramatic reduction in terms of the incidence of invasive pneumococcal disease. But just as a caution, there is a high likelihood of developing pneumonia for patients who have comorbidities. For example, pulmonary disease, you have a 4-time risk. Alcoholism, you also almost have a 7-time risk compared to a normal person. Looking at the trends through the ages, this is now among 19 to 64-year-olds. You can actually see that the cases per 100,000, this is US data, were about 16. This was in 1998. Then the first conjugated vaccine, PCV7, was introduced around the year 2000. Prior to that, we had a polysaccharide vaccine, the PPSV23, that had been around for a while. I no longer see it, but it was introduced around 1983. So the rates, you can see the rates before the introduction of the PCV7. You actually had rates as high as 16. This is invasive pneumococcal infections. And then you can see the PPSV 23 type, you can actually see they are 14. And then the PCV 13 type, they were actually 11. And then when the PCV 7 was introduced, there was a reduction of this. And then around 2006 again, because the serotypes start to change, again, there was an increase at around 2010, where here in Kenya, we actually introduced the PCV 10. In the US, they actually introduced the PCV 13. And when this happened, again, we started to have this shift of reduction of actually the incidence of invasive pneumococcal infections. Among the elderly, and this is quite concerning, the pneumococcal infection tends to be deadly in children and in the elderly. And you can see here amongst the people above the age of 65, it's almost 4 times people between the age of 15 and 64. Before you had 16 cases per 100,000. Here you actually have close to 59 to 60 cases per 100,000. So in the elderly, this infection is deadly. And you can actually see with the introduction of the PCV vaccine, the incidence rates went down. Again, they started to move up when the children started getting vaccinated. And basically what happens is there's sort of some herd immunity, that when the children start to get immunized, the rates of the invasive pneumococcal infection or pneumococcal infections, as it were, tend to decline. You can see here in the US, they actually have an adult immunization program. So these are for persons above the age of 19. And then around 2014, they actually moved to also, there were recommendations that adults above the age of 65 should actually get a pneumococcal vaccination. In Kenya, we do not have a vaccine program, but I'll come to an article that was published by one of our professors just to be able to allude to this. Now, what are the risk factors for invasive pneumococcal disease? Patients who have functional or anatomic asplenia, including sicklers. If you have altered immunocompetence, like we had mentioned, patients with human immunodeficiency virus, persons with hematological malignancies, patients who are actually abusing alcohol or alcoholism actually puts you at risk because this tends to alter your immune competence. Patients who have underlying medical conditions, like I mentioned before. So you have chronic renal disease, patients who have nephrotic syndrome because they leak a lot of the immunoglobulins, and then patients also who have CSF leak are at risk. Studies also show that persons who smoke cigarettes, this is basically above the ages of 19, are at risk. And then patients, they mainly found in the ENT, patients who've had a cochlear implant also tend to have a risk factor for this disease. Moving on to the spectrum of the disease, pneumococcal bacteremia is a problem. And in the US, more than 50,000 cases per year are actually registered of bacteremia. And the high rates are generally among the elderly and very young infants. The case fatality is quite high, with a case fatality of about 20% and up to 60% amongst the elderly. Okay. With regards to pneumococcal meningitis, 3,000 to 6,000 cases in the US. Case fatality is 30% up to 80% in the elderly. So generally, the elderly will usually, if they get a meningitis, they are probably unlikely to survive, and quite high amongst the children. There's a lot of neurological sequelae amongst this person who survive. And then there's also an increased risk in people who actually have cochlear implants, as I mentioned before. What about pneumococcal pneumonias? 175,000 cases in the US. 36% of the adults with community-acquired pneumonia actually is pneumococcal infection, and 50% of hospital-acquired pneumonia. So half of the patients who develop hospital-acquired pneumonia, the bug that you generally tend to pick is actually pneumococcal. And in about 36% of cases, you pick is a pneumococcal. So pneumococcal infection is a commonest known cause of acquired pneumonia. Of course, 64% of cases are actually due to usually viruses. So viruses are increasingly becoming, I don't think it's becoming, but it's just identification, the leading cause of actually community-acquired pneumonia. For example, in 2020, 21, 2022, and even right now, we still have SARS-CoV-2, COVID, still causing mayhem amongst susceptible individuals. We lost lots of people. I think Kenya lost up close to 6,000 people to COVID. Majority of the persons who died were actually the elderly. So persons above the age of 65 bear the biggest brunt. And to date, if you look at data with regards to COVID, the biggest risk factor is actually age. And I remember having an argument with colleagues. Some people are anti-vaxxers, and when you're young, you can be an anti-vaxxer, but just remember that these bugs are not going to go anywhere. One day you'll be a 65-year-old, one day you'll be a 70-year-old, and I can guarantee you SARS-CoV-2 will still be here, influenza will still be here, and they will wreak havoc on you. So when you're young, you may not, you may be indispensable, but as you grow older, your risks will actually go up. And that's why vaccination programs are there to cover the vulnerable. So generally, by vaccinating a large number of population, it will tend to usually lead to some form of herd immunity and reduction of fatality in those high-risk groups. So pneumococcal infections, 5 to 7%, very high in the elderly. This is an example of a patient with you can see a chest radiograph in front of you, and you can see there's actually opacity in the right side, the right lung. And for those of you who probably are adept, this is actually the middle lobe of the right lung. And this is actually, if you see a lobar pneumonia, you're almost certain that this is pneumococcus that is actually causing this. This is one thing that I've learned from one of my very good teachers, that whenever you see a nice opacification like that, then you're almost certain that it's pneumococcus that is doing this. And by and large, you want to institute the right treatment. For the younger colleagues there, pneumonia is actually a radiographic diagnosis. You may have signs and symptoms that are suggestive of pneumonia, but you only confirm pneumonia when you have a radiograph or an imaging test that you've done that actually shows new infiltrates in somebody's radiograph. Now, with regards to pneumococcal, this is just a different pictogram to just show you the incidence rates. The incidence rates when you have a chronic medical condition, your risk of all cause of pneumonia is actually high, and it's actually highest in people who have chronic lung diseases. Okay, so pneumonias will tend to cause much more problems in people who have chronic lung disease, smokers, I mentioned, people who have asthma, alcoholics, and then the other risk groups. For invasive pneumococcal disease, of course, as mentioned, alcoholism, HIV, and hematological malignancy. So basically here you have some level of immune dysfunction, then it tends to be a bit higher than the lung conditions. But for pneumonia, it's highest among persons who have chronic respiratory disorders. For all-cause pneumonia, again, the people who bear the biggest brunt are people who already have a chronic respiratory condition. This is a recent study done, and this they were looking at basically persons who've been hospitalized with pneumonia, and this was amongst population of persons with COPD. And basically, you had a comparison group. These are persons who did not have community-acquired pneumonia versus the ones who had community-acquired pneumonia. And basically, what happens if you follow them over time, the persons who had community-acquired pneumonia versus the other group who did not have a higher rate of exacerbations compared to the ones who did not have community-acquired pneumonia, to the factor of about 16% of persons who had a community-acquired pneumonia with COPD will actually exacerbate in the next 12 months. So a diagnosis of community-acquired pneumonia in someone with COPD portends high risk of actually having an exacerbation in the next 12 months. Again, this is looking at the same group, where this is now where they took one category with no COPD versus another group with COPD, and basically you can see that if you have compared to men to female, basically not so much of a difference, but basically a very high rate, about almost 10,000 cases per 100,000 of persons living with COPD will actually end up being admitted to community-acquired pneumonia. And this actually increases with age, so that by the time you have persons above 65, the risk is almost 20 times from one person who has no COPD versus somebody who has COPD. So basically, nearly 1 out of every 10 people aged more than 40 years with COPD will be hospitalized annually due to a community-acquired pneumonia. What about, because we are discussing the impact of pneumococcal infection. So this is just a slide to show the burden of what community-acquired pneumonia do to persons, for example, with COPD who are well studied, that 96.9 participants of this study actually reported missing work, with an average of 21, almost 3 weeks of missing work. So basically, if you come down with a community-acquired pneumonia, 1, you're going to miss work, and then 2, you're likely to be away from work for a prolonged period of time, almost your whole vacation. I mean, we get 4 weeks of leave every year, so you'll have almost taken out all your vacation days. The impact of this disease was also felt by caregivers and the family, where almost 85% of the participants reported needing help. Basically, after you develop getting pneumonia, about 50% of patients needed others to assist them at home. This is the impact of coughing. So you wake other people because you're coughing so much. You can't go to places that you want, and it kept you away from, for example, driving. and it kept you away from socializing. So you stopped talking or visiting other people. And then with regards to the dyspnea and the weakness that you get, then about 50% of patients reported they have problems with balance, difficulties in moving around at home. It interfered with self-care. It kept them from going places that they wanted, from visiting others because they're just too tired, and significantly from housework amongst almost 70%. So imagine an elderly couple who are codependent on each other, and when one got sick, they were very dependent on their spouse, and around 70% of them could not do housework. So basically, housework is left with one person today. So that was amongst COPD patients. What about asthma patients? Pneumonia is associated with an increased frequency of asthma exacerbations over time. So just like the COPD patients, this is a similar study where they looked at the exacerbations of asthma amongst people who had a community-acquired pneumonia. These are amongst patients who are known to have asthma, and you can see that asthma patients who had a community-acquired pneumonia had a higher likelihood of actually exacerbating in the next 12 months of actually about 20%, compared to only about 8% to persons who did not have a community-acquired pneumonia. What about persons who had recently had pneumonia amongst comorbidities that are common? So the persons with respiratory disorders reported the highest amount of worsening of their underlying condition, and they spent almost the highest amount of time before they went back to their baseline. So for example, patients who had high blood pressure, 20% reported worsening, and it took about 3 weeks for them to return to baseline. Heart disease, it took them about 40 days, so about close to 1.5 months. Diabetes, it took them about 3 weeks. Other respiratory conditions, about 2.5 months. But just look, for example, persons who have emphysema. It takes them 2 months to actually go back to baseline. And patients who have COPD, it takes them almost similarly about close to 2 months to go back to their baseline. For example, lung function, baseline function, and so having a chronic respiratory condition portends poor quality of life, and also it puts you at risk not only of morbidity but also mortality. So this was actually a questionnaire, and it was done in people above the age of 50 who had actually had a recent diagnosis of pneumonia. What about rehospitalizations? So this is another study where basically they looked at, in a 2-year period, that actually there were 8,000 cases of community-acquired pneumonia, approximately 7,500 were unique cases, and about 10% of these patients were hospitalized with a new case of community-acquired pneumonia within 12 months. So again, any person who actually develops community-acquired pneumonia is at risk of actually getting another episode of community-acquired pneumonia. I'd mentioned about comorbidities, and this increased the risk of readmission. I told you that for patients with chronic respiratory disorders like COPD, especially COPD, that their likelihood of readmission is actually high. But interestingly here, the comorbidity that had the highest risk of hospital readmission following community-acquired pneumonia was actually diabetes. That persons who are diabetic, once they got community-acquired pneumonia, had a very high risk of readmission for community-acquired pneumonia and for other comorbidities within 30 days. So these are patients who are followed up within a period of 30 days after discharge. And you can see patients with acquired immunodeficiency syndrome. Of course, in France, there are not that many patients with HIV as per their population. But of course, in Kenya, it's high, like I showed you in the first slide. Now, to come to the end of the talk, One of the reasons why it's important for us to be able to keep pneumonia under guard is the developing of non-susceptible pneumococcal infections. That the rate of pneumococcal infections that are not susceptible, so these are resistant to our commonly used antibiotics, is actually increasing. Okay, so we need to make every effort to try and make sure that we try and forestall these pneumococcal infections, simply because they cause a significant burden, particularly amongst adults with chronic respiratory conditions. Comorbidities increase your risk of pneumonia, which will increase your risk of other complications and of exacerbations. And then I'd mentioned about there being an interplay between bacteria and viruses, and we saw this during the COVID pandemic, and we still see this in patients who come down with flu, that after a viral infection, it puts you at risk of actually having a super infection from bacteria, and in three to four out of 10 of cases, pneumococcus will actually be implicated. Thank you for listening. Asante sana.
Thank you, Dr. for that. Oh, sorry, go ahead.
No, it's okay. I think after a round of questions, I'll be able to just show you the second part. I have about 2 slides about what we can do to actually be able to forestall these infections amongst our population. Thank you.
Thank you, Dr. for that informative session. From that, we can see that the impact of morbidity from Streptococcus pneumonia is quite significant, ranging from missed work days, restricted travels, and we should keep up with the work to try and achieve zero or near zero mortality from this infection. Now, one of the most important work being carried out in trying to mitigate these effects is being done by Pfizer, and I'm going to welcome our second speaker for the day to tell us more about what Pfizer is doing regarding. I'm going to welcome Mary Miguel.
Yes, good evening, everyone. I hope I am audible. Thank you so much, Dr. Bitok, for the invitation. Kindly allow me a few seconds to share my screen. Doc, can you confirm that my screen is up?
Yes, your screen is visible.
Okay, thank you. Thank you so much. I want to take this opportunity on behalf of myself, on behalf of Pfizer, and on behalf of my colleagues that are also joined in on this call to say a big thank you to the KMA leadership, to the members for the continued partnership that you have had with Pfizer, we have had with you over the years. So we truly appreciate the opportunity to come share with you what we offer, because at Pfizer, we truly believe that we bring breakthroughs that change patients' lives. And what will form basis of our presentation today, picking up from where Dr. Owor has left, and also to commend him and thank him for laying a base of what I will speak on this evening, is one of our brands, Prevena 13. To begin, Prevena 13 is a pneumococcal conjugate vaccine from Pfizer, 13 valent, that 13 standing for 13 serotypes that Prevena covers. Currently in our market, Prevena 13 offers the widest range of protection in terms of serotype coverage, and is the only one approved in the elderly or in adult patients. To echo what Dr. Award mentioned, vaccination goals, because what he said truly does resonate with our goals for vaccination with the Pfizer vaccine, is to reduce hospitalization and in turn reduce mortality rate, reduce carriage, and also achieve herd immunity. So we all get to benefit from vaccination, either directly for those that are vaccinated directly and indirectly as a community through herd immunity and reduction in reinfections one to another. I want to give a base because Doc did mention the PPSV23 that is currently not in the market. It's not a Pfizer vaccine, but forms a history of our vaccine progression over the years. The plain polysaccharide pneumococcal vaccine vis-a-vis Prevena 13, which is a pneumococcal polysaccharide conjugate vaccine. And really the conjugate technology is a breakthrough because, as we have seen with the conjugate vaccine, they elicit or generate immune memory, better immune memory compared to the plain polysaccharide. And this allows Prevena to be given in our adult patients as a single dose. So whereas for the plain polysaccharide vaccines, you would require revaccination every 5 years, Prevena is recommended as a single dose in adult patients. And we say that a booster dose is not routinely required. And even as we move forward, I will be able to show us data on the same. Doc did really lay ground on patients with comorbidity and the fact that comorbid conditions and age being one of the risk factors that predispose patients, to a higher risk of pneumococcal disease vis-a-vis their healthy counterparts. And I will not dwell much here because I believe he laid very good ground. So maybe just to speak on to some of the patients that can be targeted with Prevena, that you can begin this conversation with your patients, show them the need of vaccination, offer them the solution that is available, is in lung disease, patients with lung disease, asthmatic, patients would fall here, the COPD, patients with cardiovascular disease, diabetes, the immunocompromised, CKD, patients with HIV, and those that are maybe undergoing immunosuppressive therapies, and also lifestyle risk factors. And this doc also mentioned patients that are, heavy smokers, alcoholism, or heavy drinking. These risk factors also increase the risk of IPD in immunocompetent adults. In our diabetic patients, just to maybe give an overview, the vicious cycle of hypoglycemia, as we know that it leads to immune suppression increasing infection, infection also leading to more hypoglycemia. So just a pictorial overview of what are diabetic patients, the risk that they're opened to because of the comorbid condition that they have. And let me mention that Streptococcus pneumonia was the most commonly identified pathogen for pneumonia in our diabetic patients. The same can be said in patients with CKD. Streptococcus pneumoniae still seen to be the most frequent pathogen responsible for pneumonia in these patients, forming about 28.1% of cause for pneumonia or invasive pneumococcal disease. In rheumatic arthritis patients and patients with other autoimmune rheumatic diseases, also, these are patients that are more susceptible to infections, including pneumonia and related mortality and morbidity. And in patients with CKD, 3 to 7 times more likely to develop invasive pneumococcal disease than their healthy counterparts. And also, pneumococcal disease seen to increase the risk of complications in these patients and exacerbate heart diseases and its prognosis. Also looking at influenza infections, they open up to pneumococcal infections, and pneumococcal pneumonia has been seen to be a common secondary infection following a primary upper respiratory viral infections. And the likelihood, or there's a higher rate of hospitalization in our adult patients above the age of 65 to pneumonia vis-a-vis to when they contract influenza disease. And I think it's important here to mention that Prevena 13 is recommended and can be given concomitantly with the influenza vaccine. And I think this is important for our patients so that we reduce the frequency of coming to hospital for vaccination. So you can give the influenza vaccine together with Prevnar 13 during the patient visit. And as they come in for the subsequent years for their influenza vaccine, they are protected against pneumococcal disease from a single dose of Prevnar 13. One of the landmark studies that supports Prevnar and shows its efficacy in the prevention of IPD and pneumococcal pneumonia is the CAPITA study. It's a landmark study that had a healthy patient size of about 84,000 patients. And what CAPITA was really looking at was the reduction in pneumococcal disease with Prevnar 13. And this comprised majorly of the elderly patients above the age of 65. And for both the primary and secondary objectives, there was seen statistically significant reductions in the first episode of vaccine type pneumococcal cap with Prevnar. Let me also mention that this study is available. You can always reach out to me or from any health representative that is on this call or that represents Pfizer, and we can be able to give you the study holistically. A follow-up study, and this was a real-world setting, a study that also was looking at Prevnar 13 effectiveness in reducing the risk of hospitalization for vaccine cap, was in elderly patients. This study looked at elderly patients above the age of 65, and nearly 88% of this patient had one comorbid medical condition, and 46% of the total population of these patients were considered immunocompromised. So Prevnar 13 did show reduction for risk of hospitalization in adults above 65, and this study also complemented the vaccine efficacy that was observed in CAPITA. And we will also mention that this study is available if you would like an extract of the same. Just an overview of the Ministry of Health guidelines and to show that it does support vaccination with Prevnar 13 in our immunocompromised patient groups. In the cancer patients, Prevnar 13 recommended in HIV and AIDS patients, in sicklers, diabetic, asthmatic, and patients with chronic disease. The elderly, Prevnar 13 still recommended. And I believe also that these guidelines also include alcoholism and cigarette smoking. These are also patients that the ministry does approve and recommend Prevnar 13 immunization. I would like to echo what I began with, that Prevnar 13 is recommended in elderly patients, in patients with comorbid conditions who are more at risk of contracting pneumococcal invasive disease or pneumococcal disease, and Prevnar is recommended as a single dose for these patients. I want to say a big thank you and welcome all of you to break the silence against pneumococcal pneumonia and be at the forefront of helping our patients understand the benefits of preventative medicine and prevention against invasive diseases. And I want to say a very big thank you, and I would like to welcome any questions in regarding to the brand. Thank you very much. Over to you, Dr. Bitok.
Thank you, Mary, for that session. I would like to now encourage the audience to ask as many questions as possible. And as we do that, I will just read out the first question that I think we have, and this will be directed to Mary. Someone is asking about the cost of the vaccine.
Thank you for the question. So Prevnar 13 is available as a single vial and also as a multi-vial. It comes in ones and in tens. And the cost for the single vial is 4405, that is 4,405. And for the multi-vial, the cost of the 10 doses is around 42,000. So it's available as a single vial and a multi-vial. Our key distributors, that would be Laborex Kenya and also Sagifarm. So those are our major distributors, and these vaccines, all our vaccines are available with them. Over to you, Doc.
Thank you for that. Is the vaccine available countrywide?
Yes, the vaccine is available countrywide. I don't know if the patient has the question has any specific region, but it is available countrywide.
Okay, so we have two more questions. One of them is how long does the vaccine offer the protection? The other one is can it be safely given during pregnancy?
Mhm. Yes, so as thank you, Doc. As I began by saying that Prevnar 13 is a conjugate pneumococcal vaccine, and as we have seen with conjugate vaccines, is that they elicit a very good immune memory. So in adult patients, Pfizer's recommendation, and that is supported by data and the studies that I shared, is that Prevnar is given as a single dose, and we say that a booster dose is not routinely required. So this is a vaccine that the patient or the antibodies the patient carries long in life. So from Pfizer's standpoint is that you do not require revaccination with Prevena in adult patients. A single dose is sufficient. For the second question about safety in pregnancy, would say that we say we do not have any data that has been done with Prevena in pregnancy. So we say when the benefits outweigh the risk. So when the physician, has seen that vaccination for this mother is necessary, and they have looked at all the risk involves when the benefits outweighs the risk. But from Pfizer, we do not have any data that we have done in expectant or in pregnant mothers to show safety with Prevena.
Can I ask a question?
Yes, Dr. Orr, please do.
Martha, currently the advisory committee on immunization, that's why I've put that slide up, recommends PCV 20 and or PCV 15 and PPSV 23. When are we going to have PCV 15 or PCV 20 in Kenya? Because you see, after about 8 to 10 years, the serotypes change. I think right now the one that is common is serotype 8, which I don't think the PCV 13 covers. So my question is, when do you foresee us getting the PCV 15 or the PCV 20? Thank you.
Yes. So, Doc, let me say that that information has not been availed to us as of yet as to when we expect PCV 20 to be available in our market. But then our marketing is on the call. I don't know if he has any updated information in regards to the same. But as of now, as Pfizer Kenya, we have not got any communication in regards to the timeline that we expect these vaccines, the PCV 20 or the PCV 15, into our market. So maybe Kimathi, if he's here, if he has any information of the same, he can always share with us. But I will still liaise with our medical team and get feedback on the same.
Thank you.
Thank you.
Okay, I encourage the audience to still ask more questions. We still have time for the same. In the meantime, I will hand over back to Dr. Wall to share. There was some slides that he wanted to share.
I already put them up.
Oh,
I already put them up. I think they were up. Basically, what I wanted to just show was what is currently being done. Let me just try and go back. So there have been some changes with regards to pneumococcal vaccine. The PCV 15 came out around 2019, and we've had PCV 20, which came out in 2021. Basically, it's an attempt to cover as many serotypes as possible, because some of those serotypes confer high morbidity, and there are some that confer actually high mortality. I think serotype, if I can't, serotype 8 tends to confer a lot of morbidity, so it will usually cause a lot of people getting sick. It's not very lethal, but it's quite prevalent. So as time goes by, the bug also is trying to survive just like we are. Now, there's the slide that I put was this was an article published by Professor Rina with other colleagues, and basically is a case for implementation of adult pneumococcal vaccine program in Africa. And you've seen in our national guideline, it's actually indicated vaccinating the high risk groups, patients with chronic medical conditions, and then the elderly. So if you're 65 and above with no comorbidity, you are also at risk for invasive pneumococcal vaccination. And basically what this article was talking about is that we need to establish and emulate the childhood vaccine programs for the adults. For example, we actually have guidelines, but we do not have an actual program for vaccination for adults. Two, for these vaccines, the adults have to pay out of pocket, and like the childhood vaccines, which are funded by the state. So these are attempts that we're actually trying to make in terms of increasing vaccination amongst adults and patients with chronic medical conditions. And then lastly is actually the role of you as a healthcare provider by recommending vaccination to your adult patients, especially the ones who you've seen we've listed or outlined in our presentation. So patients with chronic respiratory conditions, especially COPD, asthma patients, patients with HIV, patients with hematological malignancies or hematological conditions like sickle cell, persons with chronic kidney disease, because kidney disease also puts you at risk for infections. They have a dysfunctional immune response, diabetic patients. And one of my colleagues who's an endocrinologist, she actually usually tells me the way after she instituted, we had a discussion after instituting vaccination amongst her diabetic patients. Actually, for both flu and pneumonia, she rarely admits her patients to hospital. So they tend to they come to her clinic, but they rarely get admitted. So that just tells you how much vaccination does to patients, especially with chronic medical conditions. I would recommend for those of you who manage patients with chronic medical conditions to actually vaccinate. This is actually the matrix that was designed by Rina and Co. Government, funding vaccine provision, because for adults, these vaccines are not provided. The only vaccine that is provided by the state is actually the SARS-CoV-2. The COVID vaccine is the one that is state funded. However, influenza and pneumococcal pneumonia still continue to be a burden to persons. So yes, COVID is under wraps, but we still need to vaccinate against pneumonia, pneumococcal infections, and actually influenza. Case in point, I think this year I've had the largest number of influenza cases than ever before. I do not know why, but these viruses tend to be quite interesting. We left SARS-CoV-2 last year, and this year quite a big problem with with influenza vaccine and influenza infections. And of course, these patients, if they land in hospital, then they'll by and large may also have a superadded pneumococcal infection. I don't know any of you, whenever you admit a patient with pneumonia, you put them on antivirals or you start them on pneumococcal infection treatment. Okay, so majority of us will usually treat these patients with antibiotics, and we can't wait because resistance to antibiotics is increasing, both for community-acquired pneumonia and hospital-acquired pneumonia. And then lastly is there's a latest recommendation. This is 2023, actually 2022 recommendation. We are yet to get this. We usually tend to get these vaccines a bit later, I think 3 to 5 years later. But as I mentioned, there's PCV 15, which now covers for 15 serotypes. The attempt is to try and get a vaccine that is conjugate, because Martha mentioned the challenges with the polysaccharide vaccine, that the polysaccharide vaccines only elicit a B cell stimulation. However, the conjugated vaccines actually elicit a T cell dependent. So basically, you end up having humoral response. So the T cells will usually be able to, your T memory cells will be able to remember. And basically, that's why she's mentioned that you only need one shot of the conjugated vaccine, unlike the polysaccharide vaccines where you required a booster every 5 years. So I'll leave it at that. Thank you. Unless there are any more questions we can take.
Thank you, Daktari. So maybe just one last question. Is it someone is asking, is it safe to give to a client the vaccine, someone who has active respiratory symptoms?
So the recommendation is generally to wait until the person does not have active respiratory symptoms, because you could be vaccinating them against what they actually do have. So generally, you want to wait for a period of about 6 weeks to actually, 4 to 6 weeks to actually vaccinate patients whenever they have symptoms. So when they have active symptoms, you want to wait. This is across all the vaccines, whether it is a COVID vaccine, influenza vaccine, or the pneumonia vaccine. You want to wait for about 4 weeks before you are actually able to give the patient the vaccine. So if your patient has active symptoms, you want to wait, give them a return date about 4 weeks later, and kindly vaccinate the patients. So somebody had asked who is eligible for the vaccine. I don't know. Mary, do you have a slide on who's eligible? But basically, to just run through chronic medical condition, those ones are eligible for vaccination. Persons above the age of 19 with any chronic medical condition do qualify. Persons who smoke, if you do smoke and you're 19 years and above, you qualify for vaccination. Persons above the age of 65 without, if you have a chronic medical condition, then you qualify. If you do not have a chronic medical condition, then at the age of 65, you should actually get vaccinated. I think they've tried to bring that age a bit lower. I think, Mary, you can clarify that, down to around 50, so that at 50 you get your shot and you're good.
Yes, Doc, I agree with you.
Over to you, Dr.
Thank you very much for. Yeah, I think there are no more questions, and I'm now going to hand over to Dr. Simon Kigondu, who is the president of the KMA. It's been a pleasure hosting you for this session, and I appreciate you for attending. And I hope everyone has learned something this session, and I'm going to wish you a lovely evening and a good weekend. Welcome, Dr. Simon Kigondu.
Dr. Kigondi is not available, but on behalf of KMA, thank you all for joining in this webinar. If you registered using your KMPDC registration number, be sure your CPD points will be automatically reflected on the new ICPD system. Thank you very much. Have a nice weekend.
Good evening to you all, and have a nice weekend.